My name is Dr. Hamish Philpott. I'm an adult gastroenterologist working in Adelaide, and I have a long-standing interest in eosinophilic esophagitis, dating back from about 2012, and my research and clinical work mainly focuses on this condition. I'm very delighted and honoured to be part of these talks aimed at educating and increasing awareness of eosinophilic gastrointestinal conditions, and I'll be talking about treatment of EoE in 2021, what's available and that we use, and perhaps a little bit on what we might be doing in future years. I often talk to other doctors about eosinophilic esophagitis, but tonight or today we have a more generalised audience. I find my patients with eosinophilic esophagitis and their families are often very well informed and curious, so the slides that I'm presenting are very much like what I would be presenting to other doctors, but I have filled in some additional information here or there, perhaps to explain some of the medical terminology that not everyone would be used to. So eosinophilic esophagitis, and I'll use the term EoE from now on in. A person with this condition will have difficulty swallowing, which we call dysphagia. They will have episodes often where their food may literally become stuck in the esophagus. The esophagus is the food pipe, and a person may have generalised discomfort or pain even behind their breastbone or sternum. It's worth knowing that only by having an endoscopy, which is when we insert a specialised video camera down through the esophagus, and by at the same time taking specimens of tissue, known as a biopsy of the tissue, can we make this diagnosis. And the diagnosis rests on finding numerous allergy cells, known as eosinophils, in these biopsy specimens. So at the moment there are no blood tests to guide treatment or to make a diagnosis, and symptoms don't, because a lot of people have difficulty swallowing or dysphagia for other reasons. What causes EoE? Well, it is a food allergy. So if we got all patients that have EoE to not eat proper food, but to eat what we call an elemental formula, then almost all of them would get better. But of course, that's not a very feasible thing to do. So when a person swallows food, it will be one or more of the foodstuffs, for example, it might be, say, gluten or dairy food, will cause these eosinophils or allergy cells to be attracted to the esophagus, and then they'll cause the problems. So this is the technical stuff. You've got a person with eosinophilic esophagitis there on the left. So their esophagus, the wall of it, which is demonstrated there, becomes thickened. There are those purple eosinophils everywhere that you can see, and they are the mischief makers. They cause the wall to become thickened. The muscular layers, as well as the lining, or what we call the mucosa, become thickened. It become quite scarred or fibrotic over time, and that will mean that the food cannot pass as easily. So why does it matter? Well, to the individual, of course, eosinophilic esophagitis matters because they have difficulty swallowing, they have symptoms. To society as a whole, it matters, however, because this condition is increasing rapidly. It's not just because we know more about it or that we're looking for it harder. It's increasing irrespective of the number of endoscopies performed. And it seems to be increasing in concert with other allergic conditions. So children in general are getting allergies more often, whether that be food allergy per se, eosinophilic esophagitis, dermatitis, what have you. So it's becoming more important, it's becoming more common, which is important. It affects all age groups. I've got patients in their 80s with this condition as well, and paediatricians will see very young children, little babies. The end point, of course, is that you get a very, very narrowed esophagus, which will permit virtually nothing to be swallowed. A colleague of mine had an individual that couldn't swallow a pea, literally. It got stuck, and then you need to treat it. So why treat it? What are we aiming to do when we treat eosinophilic esophagitis? We're aiming to relieve a person's difficulty in swallowing, relieve their dysphagia, make them swallow better, prevent food literally getting stuck, which will often mean that a person would otherwise have to go to hospital and have an endoscopy, quite disruptive, and obviously improve quality of life. So if you have eosinophilic esophagitis or someone that you know, you may be aware that you will take, or the person will take measures to minimise these events. So they may eat different foods, they may stay at home, and they may have a worse quality of life as a result. And it is thought that by diagnosing efficiently and treating adequately, that it will prevent things getting worse and prevent a state where, things will be more difficult to treat, having more therapies, more endoscopies, and so on. So this is a bit of a technical slide here, but what it basically says is that there was a group of doctors in the Netherlands, in Amsterdam, I believe, and they looked at about 10 years of their experience in treating patients with eosinophilic esophagitis. And what they found was that when there was a delay in making a diagnosis and initiating treatment, that there was a greater likelihood that the person would have strictures. So a stricture is when the esophagus becomes very narrowed and scarred, and that can be more difficult to treat because a person might have to have stretching of the esophagus or dilatation. So the earlier treat, the better. The other side of things, as we said, was quality of life. So there's some evidence that individuals with EoE have a higher likelihood of developing anxiety and depression, and this seems to relate to the duration of the EoE again. So you need to treat early to prevent this occurring. So what are we aiming to do, and what can we do? We've said what we're aiming to do, which is stopping the symptoms, improving quality of life, but what can we do? At the moment, if you go to a doctor or a specialist and you seek treatment for your eosinophilic esophagitis, there are 3 accepted options available, and we call these first-line options. That means that any one of these 3 could be started. You don't necessarily have to go in order, although many doctors would start with a proton pump inhibitor or a PPI because they are easy for the person to take. You just swallow a tablet once or twice a day and that's that. So these are the 3 options, and we'll take this one at a time to tell you what are the pros and cons, what are the benefits of either or of these treatments. As that box that I've just slipped in there indicates, first line implies that they're readily available, could be used in either order, and that there's good evidence that they work. This is what they call a treatment or therapeutic algorithm, and this shows doctors how to treat a patient with EoE. And you can see that any of those 3 options can be used, and you use them one at a time. And when it talks about histological remission, you can see that it says that in each case. It means that after a period of time with one of these treatments, you might say wait 8 weeks and then you have another endoscopy. Histological remission implies that you need an endoscopy. So every time we make a treatment change, we perform another endoscopy and take biopsies, as I've said in my very first few slides tonight. So what are proton pump inhibitors, or PPIs? These are medications that are taken orally, you swallow them. They act by decreasing the acid produced by our stomach. And the reason that this treatment is used in EoE is that we know that all human beings reflux some acid from their stomach back into the esophagus. That means that there is acid that normally would reside in the stomach and helps us digest food, but all of us have some movement of that acid back into the esophagus. So Using proton pump inhibitors doesn't address the food allergy side, but it does remove an irritant factor that otherwise stirs up or increases the swelling in the esophagus. So one thing I say to my patients, imagine you had dermatitis. If you had dermatitis or eczema, you might be allergic to, say, dust mite, but you may not be able to get rid of all those dust mites. However, if you avoid hot showers, hot baths, and harsh soaps, then removing the irritant factor may well take away your dermatitis. Similarly, with EoE, we know that by taking proton pump inhibitors, a significant number of patients will, by removing this acid, remove the irritant factor, and their esophagus will normalise. The EoE will go away. So you can see there, the green blob, that's your stomach, filled with acid. Now, if some of that acid moves upward into the picture along the long pipe, which is the esophagus, it will cause that irritation, and it may, in many cases, drive or exacerbate the EoE. A couple of points here. If we started a proton pump inhibitor on someone, say you take PPI yourself because of your EoE, and you get better, it doesn't mean that you've got gastroesophageal reflux disease. It just happens that people that have gastroesophageal reflux disease, that is when they get ulcers in their lower esophagus because of the acid, it happens that proton pump inhibitors were invented for this condition. It subsequently found out that a good percentage of individuals, a good number of individuals with EoE, which is a food allergy, respond. Okay, so it's known that PPIs help EoE, and that's what they do. Around 50%, so half of people with EoE will respond to a PPI, and by a PPI or proton pump inhibitor, you may have heard of the trade names Nexium, Somat, Pariet, or they all have proper names. So any one of those agents, if used twice daily at a good dose, 50% of people will respond. And we know actually that you don't have to take it twice a day in the long term. The majority of individuals, majority of people will be okay if we drop down to daily administration. So you can see this is a pretty convenient treatment for a lot of people. This is a summary diagram of a really big study of 630 patients treated in centres throughout Europe. This was published in a medical journal, well-known medical journal. And it basically shows that a bit over half of individuals with EoE will respond to a proton pump inhibitor, to a PPI. And this is a summary slide of a large number of studies. These were more scientific studies rather than real-world data where lots of doctors just entered in their patients like the previous slide. These were specific studies that were performed to see who responds. And you can see around about 50% respond. Once daily dose does seem to be effective. So this study here done by a Spanish group found that when they decreased from twice daily to once daily, more than 80% remained well or in remission. That is, the eosinophils didn't come back into the esophagus. And the other big question that a lot of my patients ask me is it safe for me to take PPIs long term? Regardless of the condition, individuals want to know, is it safe? Once upon a time, there were some studies done that suggested that wasn't the case, but more recently, all of the studies suggest that PPIs are indeed safe. This was one very large study of almost 20,000 people, indicating complete safety over a 3-year period, where they studied these individuals intensely, checking out their heart and lungs and every other conceivable health check. And gastroenterology colleges around the world do issue position statements that people can stay on proton pump inhibitors for a very long time, and that this is considered safe. So that's the story for our first treatment, proton pump inhibitors. We then move on to our second, which is also a medication, and we call these ones corticosteroids. And topical corticosteroids, that means applied locally. That might mean, for example, a person, in the case of EoE, swallows something that coats their esophagus, or in the case of asthma, they inhale something that lodges in the lung. So in EoE, we get people to swallow something that coats the esophagus. And we know that topical corticosteroids like this are very effective. Probably our most effective first-line treatment, because more than 60%, or about 2/3, respond. This is a summary slide of a large study performed on individuals with EoE, and you can see that more than 50%, 55% or so, responded to topical corticosteroids, more so than those responding to proton pump inhibitors. Again, we're looking at those that responded with demonstration with a biopsy and taking those eosinophils at the time of endoscopy. In Australia, we don't really have a dedicated medication for EoE currently, not one provided by our pharmaceutical benefits scheme. So we have to either use medication, we do have to use medications for asthma, and then this would involve using fluticasone or Flixotide, which is a dry powder inhaler. And rather than inhaling it into the lungs, a person would swallow that dry powder once or twice daily. Or an individual could get budesonide slurry, known as Pulmicort, and this is a nebulizer, so it's 1 milligram and 2 ml nebulizer solution, and then you go and get yourself some Splenda from the supermarket or chemist, which is an artificial sweetener of sucralose, and you mix the two together to make a slurry or gel, and then you swallow that one twice daily. So at the moment it's on an ad hoc basis. Ad hoc, meaning you've got to do it yourself, a bit of work involved, but it's still effective. And many of the studies that have been done on topical corticosteroids have been using these ad hoc solutions. Recently in Australia, a commercial product has become available in a limited sense. It's not currently on the pharmaceutical benefits scheme, but the pharma company called Falk do provide this free of charge for 12 weeks if you go via your treating specialist. And in the new year, I'm told that it's likely that this medication may well become available for use in eosinophilic esophagitis. So if you're interested in a tablet that is commercial, therefore it dissolves in the mouth, there's no requirement to mix things up or to swallow a dry powder. If you're interested in that, then you'll need to speak to your local specialist who can gain access via Falk Pharma. This is some data on this dissolvable tablet showing very high rates of response. You can see there that the red and green bars show the individuals that got better, and they were taking a variable dose of this dissolvable tablet, and the placebo, those that were not taking any active treatment, are in black, and hardly any of those are in remission, whereas most of the patients taking the individuals taking the dissolvable tablet were better. So it was a very effective treatment. This was some individuals that I treated way back in the day using the slurry when you mix the Pulmicort ampule with your Splenda, and I found similarly high rates of response. So topical corticosteroids certainly work. The question that I'm often asked by my patients or the family of my patients is, are these topical corticosteroids safe long term? Steroids have a bad rap, I think, and that's because in the old days they were given at very high doses for a very long time. And this would be something like prednisolone, for example. You've got to remember that when we're doing the budesonide as a slurry, this is a very small dose. It's 1 milligram twice daily, okay? As opposed to a person taking prednisolone who might be taking 40 milligrams or more per day. So this is a well-tolerated medication. Very occasionally, 1%, 1 in 100, I should say, people might get oral thrush, so a white fungal infection of the mouth, which is readily treatable. All right, and then there's been concern in the past of what we call adrenal suppression. That is, would taking these medications lead to problems with what we call our endocrine system or our glands. You know, would this cause diabetes or another condition called Cushing's syndrome that you may have heard of? I was involved in a study supervised by a well-known doctor from overseas called Evan Dellon, and we looked at all the previous studies performed. We performed a systematic review. We looked at all the previous studies that had given this medication and that had tested for this adrenal suppression. And the good news is we found no evidence that you do get adrenal suppression in individuals taking steroids, topical corticosteroids for EoE. I'm very confident in saying that in adults because most of the studies are in adults. There's no real danger signal, I think, shown in any of these studies. One common sense thing I would say is that if an individual was taking steroids for other reasons, say for their hay fever and their asthma, and then you were doubling or tripling up in terms of the EoE, then you know the overall steroid dose would be increased, and that's perhaps where some caution could be exercised, and you'd be trying to steer away from this treatment for your EoE if you're already using steroids for another indication. But that's being very cautious. As I've said, there's nothing to suggest these medications are dangerous at this time. And they're probably our most effective treatment for EoE for taken first line, with almost 2/3 of people responding. The third treatment that we have readily available for us is what we call elimination diet. And what we talk about here is empirical elimination diet. Empirical meaning you don't have a test and say, hey, you're allergic to this food or that food. And in fact, a key thing to know with EoE is that no allergy tests are reliable in predicting which food you're going to be allergic to. Not for your EoE, because it's not like other allergic conditions. It's slow onset, slow offset. Skin prick tests don't work. Okay, if you've got an allergy for another condition, say you've got anaphylaxis when you eat shellfish, clearly you would avoid that. But that's not what we're talking about. We're talking about your EoE, where you'll gradually develop swallowing problems, and then when you go on treatment, then you'll gradually improve. Okay, so the empirical elimination diet, that is when you avoid a specific number of foods, whether it be 3 or 6, that has can be effective in about 50% or so of patients. And it's appealing, isn't it? Because EoE is a food allergy. The problem is that in practice it can be a little bit more difficult. Now, that doesn't mean we shouldn't do it, and in fact I encourage all of my patients to consider this, particularly the youngest patients where you're going to be thinking about a lifetime of medication otherwise. So the common food triggers are gluten, dairy and eggs. They're the 3 big ones in my experience in Australian patients, and then legumes, and then in an order of decreasing frequency into causing food triggers, then finally nuts, and then fish or shellfish. So the commonest trigger in adults is gluten, and in children it's probably dairy followed by gluten. So gluten and dairy are the 3 big ticket items, followed by egg, which is also quite a big one, and then the rest are a little bit less common. You might say, well, it's a food allergy. Why can't you just take an individual off all foods that are likely to cause allergens? Indeed, you can. They're likely to cause food triggers or cause the allergy. You can do that. You can give someone what's called elemental formula or diet, and that reduces food to its most elemental form, as the name would suggest, and it does essentially take away the problem for a period of time. And this can be used particularly in much younger people, in young children that are failing to thrive and not growing, as an emergency intervention. The problem, I think, and particularly in adults, is that it's poorly tolerated. You're taking a fairly tasteless kind of grey emulsion. You're not having anything to chew on. The quality of life is poor. It's expensive. It's not going to be a sustainable long-term option. Moreover, you don't know which of the foods that you otherwise would be normally taking, are causing the problem. There's no logical step-off point, in my view. So it can be reserved for kind of emergency situations where, say, a younger individual is not able to swallow at all and therefore not get nutrition. Just to give you a bit of an idea why this is difficult, you know, I originally started by using a 6-food elimination diet where you'd avoid all these 6 foods. And then I would reintroduce, I'd get my patients to reintroduce 1 food at a time for about a month. And then each time they'd had a food, the new food for about a month, they would undergo an endoscopy. So you can see in this case, say the person went into remission on the 6-food diet. So they'd have an endoscopy here to confirm that they went into remission, then would reintroduce seafood. That's their 2nd endoscopy, 3rd endoscopy, 4th endoscopy, 5th, 6th, 7th. So you're having a lot of endoscopies to try to see whether you have a food trigger. And then if you do have a food trigger, say you had an allergy to egg, you had a lot of eosinophils at that endoscopy here, then you would have to have a period of washout where you went off the egg, waited a good period of time, maybe 10 weeks, and then you would start the milk, and then you have another endoscopy. So this is a long drawn out process because there's at least 4 weeks between these ones. Then if you have a food trigger, you need a washout, so you might need 10 weeks. So this whole thing, this might take best way of a year if you went off all 6 foods. So you can see that because of these difficulties, and difficulties by this I mean how difficult it is to remain compliant to the diet, we see that only about 20% of people do respond, as demonstrated in that previous slide. So, and then you've got the issue that often an individual may have more than 1 food trigger. So it's with these things that in the real world practice the diet can be difficult. Not so difficult that we don't use it, but just be aware that you've got to choose carefully if you're going to want to do this diet and really embrace it. I no longer start the 6-food elimination diet. I go for one of 2 options. I either use the 3-food elimination diet on Australian patients, and I'll talk about that in a second, or another way to approach this is what we call a step-up diet. With this step-up diet, which is demonstrated in this quite complicated algorithm here from the Spanish group, they remove from the diet the 2 most common food triggers in EoE, which, as I've said, are gluten and dairy. And then they would wait for a period of, say, 6 weeks and perform another biopsy. And if the individual responded, that's fine. We know it's one of those 2 foods, and then you would reintroduce one of those 2 foods to identify what the trigger was. If not, though, you would go from being on a 2-food diet and you would step up to a 4-food diet. So you would add to your gluten and dairy elimination egg and legumes including soy. Then you'd wait another 6 weeks and then undergo another endoscopy and so on. And if you still weren't in remission, you'd go up to a 6-food diet. So it's the situation of in reverse, really. You start with a small number of high-yielding foods, the ones that are most likely to cause a food trigger, then introduce the less common ones until such time as you induce a remission. And you can see in this that a good number of patients did achieve remission. It's actually pretty logical, isn't it? You're on a 2-food, you're on a 4-food, so 2-food about 40%, 4-food about 60%, 6-food about 80%. That's remarkably good. Maybe that implies that by starting slow and adding foods in, that you get better compliance. So this, you'd start off with gluten and dairy for 6 weeks, wait 6 weeks, repeat your endoscopy, take specimens. If in remission, then we know it's one of these 2. If not, then you add in 2 more foods, e.g. eggs and legumes, all right? So look, dietary treatment is complicated. You would need, if you're a patient with EoE and haven't tried dietary therapy, you would need to get a gastroenterologist or other specialist that has a specific interest in EoE, and you need to follow things through very precisely. And if you've got questions about the diet that you cannot answer with your, say, your gastroenterologist or by online resources, you may need to seek a dietitian's input there. That might be very useful. This was just some data from when I was doing my PhD back in Melbourne years ago, and you can see that the majority of the food triggers, gluten was the big one, dairy, then you see egg a bit, then you see some that have got both dairy and egg. You got one person here that had two people had 3 food triggers. That's very difficult to deal with, but gluten, dairy, followed by egg, by far and away the commonest triggers in this group. Okay, so that's why I advocate a 3 food elimination diet, and that's been shown in Australian patients in our group, but also in North American patients that these are the 3 commonest triggers. Legumes or soya is an issue more so in Spanish research that's been shown in Spanish patients. So let's recap then. When we're thinking about starting treatment with EoE, we have 3 viable options to consider in any one order. Often, PPIs are used first, proton pump inhibitors are used first because they are simply tablets or capsules swallowed initially twice daily and tapered down to once daily if they work. Okay, and that is a safe treatment when used long term, and I've said that, I've shown you that. Topical corticosteroids such as budesonide or flixotide are safe and effective, and are safe and effective long term, particularly when they're used as the only steroid. We have some concerns if you're using multiple steroids, e.g. for asthma or hay fever, but they are used and they're effective. The third first-line treatment is in the empirical elimination diet, and I've given some ideas as to how to use this in a more efficient way. And if, as a patient, you are very engaged and precise, you can expect more than a bit better than half chance of responding to a diet like that, but you need a few endoscopies. All right, so they're the 3 first-line options. You might ask, well, what am I going to do if I don't respond to them? Indeed, some people don't respond to them, or some people do not tolerate them and want to look for something different. What else can we do? I often get asked about dual treatment. Can I just take 2 treatments at a time? You might want to. I guess it depends on how you're going to do that. If you were to just start 2 treatments after finding out you have eosinophilic esophagitis, it's going to be very difficult for you to know which one is effective. I often inherit patients like this. And my first thing that I do is to actually put the individual back on one of the treatments and establish which one is working. There's not a lot of data supporting the use of dual treatments, and I think that's because if you think about it, would you really want to be on both a proton pump inhibitor or PPI and a steroid long term? Probably not. Ideally not, although you would if you were really struggling, I suppose. What about diet and one of the other treatment methods? There have been some papers where they looked at, there has been one paper, I should say, when they compared diet and PPI versus diet alone and found that PPI and diet is more effective. That might be an option. We don't have a lot of data yet. So what else have we got? There are new medications on the horizon. I've titled this slide The Biological Era. Now, biological often implies antibody treatments. So we have antibodies are things our bodies produce that fight infection or might bind to a cell, say you had a bacteria, which are like a single cell organism that go into your body. There may be some antibodies that fight that bacteria. So if you have an immunization, you get your vaccines, that they would be an example of antibodies helping fight a disease. Similarly, or fight a bacteria, I should say. Similarly, in disease states, we now use antibodies to fight disease. So you can see here this anti-word, anti-IL-4, interleukin-4. Interleukin-4 is a receptor, a little like a port or a little tag on various cells in our body, including eosinophils. And so if we block this message, this little port on those cells, there no longer is that stimulus for the eosinophils to accumulate. So we have a few of these biological agents that have shown significant promise in the treatment of EoE. So these top 3 in this table have been trialled, more in trials as opposed to available to the general public. I've had experience with the dupilumab, this one, and this one here, ongoing experience with this one here. Dupilumab, this study is largely closed. And these treatments are very effective, albeit they're given intravenously, okay? So at the moment, I would see that these biological treatments administered intravenously would be for individuals that have failed to respond to everything else. So if you've had EoE, you don't respond to everything else, you're really struggling, and you're interested in intravenous treatment, maybe administered every month or 2, these might be things that you'll consider. These trials, these top 3, I think are in progress or about to close. So it may be difficult to get on these, but this just gives us a bit of an idea as to what might be available into the future. And certainly, again, involvement with your, say, your gastroenterologist that has a particular area in this, or awareness of online information areas like, for example, EoE here in Australia will alert you to the availability of these studies. This one here, etrasimod, is interesting because it's going to be an oral medication, and that trial is beginning in Australia now. And that might fit in for someone who hasn't responded to the other first-line treatments. That it might be this medication. Again, all of these studies, though, they are studies. There's limited recruitment, and it's just being aware and maybe being at the right place in the right time. But I would say that there is light at the end of the tunnel for people that haven't responded in terms of their treatment of EoE. I should finally say that EoE is a chronic condition. Okay, so you've got to be aware that what's happening. You might want to update what your treatment is over time. You should be checking in with your specialist, your gastroenterologist, every few years. It's likely that you'll continue to have your EoE once it's there. It's very unlikely that it will go away. And my practice would be to repeat an endoscopy off treatment every 3 years, just in case there is some spontaneous resolution, to give the individual that small possibility that things have burnt out or improved. We don't really know whether EoE will ever go away yet. We do know other allergic conditions like asthma and hay fever lessen over time. But at the moment, once you've got EoE, it's there for good. It's a chronic disease, and you do need to keep in contact with your team of doctors and get checkups. So this is all a bit heavy, but it just really shows this dupilumab, which is a medication targeting interleukin-4, which is involved in allergy. The medication is originally used for dermatitis, and it's been really effective for people with EoE. You can see the placebo arm of these, and the numbers of people in remission or change or decrease in the eosinophils or symptoms from baseline. So really quite good. I think up in the range of 70%. So better than our current treatments, or at least as good. And then IL-13, good, but perhaps not quite as strong. Still promising. And then this anti-cyclic 8 article published in the New England Journal of Medicine, our most prestigious journal in the field of medicine, showing that this really is a medication to look out for in the future. This was for eosinophilic gastritis and duodenitis. There's an ongoing trial, including in Australia, of patients with EoE, demonstrating significant improvements in eosinophil count. Here, this is obviously in the stomach and small bowel, but up to 90% improvement. Very powerful treatment, again, intravenous. So let's bring this back to the here and now, the day-to-day. We have 3 first-line therapies to choose from in EoE. The good news is they're all effective. Not every treatment will be effective for every person, but they all do have proven efficacy in a percentage of people and are proven to be safe. We try one medication at a time. We monitor with an endoscopy. Anytime we change treatment, we have another endoscopy. And I've given some tips as to how we do that along the way. There are new therapies on the horizon, and they show significant promise. So I think here and now in 2021, we should be looking forward with some confidence and with some optimism. Never before have we been better informed about how to use these first-line treatments, and never have we been closer to other treatments becoming available, even beyond the clinical trial scenario and into real-world practice. So thank you once again for giving me the opportunity to speak in this EoE awareness platform. The condition has been of great interest to me. I've enjoyed treating and interacting with my patients and their families, and I hope you find this talk and the rest of the talks useful. And thank you once again for listening.